So let's talk about reflux. Okay, so I don't know if when you guys were in the NICU, you actually got an explanation as to what it is. So when we are swallowing, we have milk or food in our mouth and we swallow it. It goes down the esophagus, which is a long tube, into the stomach. And then from the stomach, it goes to the rest of the small intestines. But when you look closely in a normal adult, in a teenager, in a child, there is a narrowing or a tightening here at the junction between the esophagus and the stomach that is a sphincter. And what a sphincter is it's like a little band of muscle that tightens so that it gets the signal that the food is coming, it opens up, lets the food into the stomach, and then it tightens again. So then that way when the stomach is churning, the food isn't coming back out the top, it's instead going forward into the small intestine where it can start to be digested and absorbed. In all babies, whether you're preterm or full term, this sphincter is open, it's loose. And that's regardless if you were born at 27 weeks, 30 weeks, 32 weeks, 34 weeks, 40 weeks. It's all babies, it's loose. And so what happens is when the stomach starts to churn, milk and gastric juices and all sorts of things will come up the esophagus. Now, in full-term kids, they're bigger, they have more muscle tone, they probably have a little bit more head control, though newborns don't have great head control. So they're able to manage it when the milk is starting to come up a little bit more easily than preterm babies. Preterm babies, because they're a little more immature, they tend to have more side effects or symptoms from the reflux happening. And not only that, they have immature motility. So kind of the whole digestion tract has kind of waves of peristalsis that move things forward in a forward manner. And in premature babies, that's immature. So it's not, the milk might be sitting a little bit longer in the stomach than it would in a full-term kid, which gives it more time for it to reflux up the esophagus. So that's why a high percentage of premature babies tend to have reflux. So what are some of the symptoms that we see in babies from reflux? We can see non-projectile or even projectile, effortless, meaning that they're not kind of forcing it to come out. It just comes out, milk comes out, and it's regurgitation of milk from the mouth or the nose. And they just seem like they'd be sitting there and then bleh, milk everywhere. It won't need to be stimulated, it could just come. Vomiting, so in addition to it just coming out or spewing out, they can actually throw it up. They can be irritable, they can have unexplained crying, they can do body maneuvers that indicate they're uncomfortable, like arching the back. I'm sure you guys have seen the babies kind of arching to get away from something. And then they can make facial expressions that indicate they're not happy, like grimaces or like, I'm in pain or something like that. And then sleep disturbance, especially in the period right after the feeding. Because the goal, you feed them and you want them to go down and to sleep so then you can maybe get something to eat or sleep yourself. And so if they're not going down easily or if they're having problems with reflux, it may make sleep difficult. And then sometimes if it progresses to the point where babies are really associating the reflux with feeding, they may not want to feed. They'll be like, no, just I know that something or pain is coming next or something like that. Do the next slide. So as I mentioned, all babies experience reflux. But a higher percentage of preemies experience reflux. So if in full-term babies who are healthy, normal newborns who go to the nursery and go home, about 50% of those infants are going to have reflux. And then if you think about it, then in premature babies, it's going to be even higher. It's going to be 75 to 80% are going to have reflux. And there's tips and tricks that we'll talk about now to see if we can give you guys tools to help make it a little easier, a little bit better. The good news is this will all go away. It may not be easy, it may be difficult, but it will over time go away because that sphincter will naturally tighten. So in, I would say, full-term babies, reflux can be an ongoing issue in addition to preterm babies, at least until a year of life. So some of the more severe cases. Most cases are resolved between 6 and 9 months, but the really severe ones can go all the way up to a year, but they all do eventually get better and go away. So when you go to see a doctor and they say, you have reflux, like now what do I do? So general pediatricians sometimes feel comfortable treating and dealing with reflux. Sometimes they may not feel comfortable and they may want to refer you to a specialist. It would be a gastroenterology specialist, a pediatric one who deals with reflux. But there's kind of medical treatments and there's non-medical treatments. So we'll talk in a little bit more depth about the non-medical treatments. And then the medical treatments I'll mention, but they're not necessarily for this discussion. This would be something, if your pediatrician was interested in putting you on, then they would have the discussion with you guys about it. So I'll just quickly mention the pharmacological treatments and then we'll get into what we want to talk about, which is the non-medical treatments. So there are 3 different types of medications that you can use for reflux. And in the NICU, we do sometimes use these. So your babies may or may not have been on some of these medications. We try not to discharge babies home on these medications because giving it just time and giving them a little bit more maturity, more muscle tone, more head control seems to make things better. But you have the acid reducers, which are the Pepcid Zantac. You have another type, so this is actually a neutralizer. Then you have the acid reducers, which is the Protonix, Prilosec, Nexium. And then you have prokinetic agents that actually make your GI motility go a little faster so that you don't keep the milk sitting for as long. And that's an antibiotic. It's called erythromycin. So we do use some combination of these sometimes in the NICU, but we try not to send kids home on them because we know that this is an ongoing problem. You don't want a kid to take a medication for a year of life. If you have to, you have to. It's totally, if you need it, you need it. But if you can avoid it using the non-medical tricks and tips, then it would be better overall. You don't want to take any unnecessary medication. So there are a couple of different non-medical treatments that we would do. So in the NICU, you guys probably remember we use body positioning as our #1 thing. And actually, Dawn, can you come and show us with the baby what is the optimal reflex body positioning, or Jenny, either one. So we like to put babies prone, and you know that the FDA says that all babies need back to sleep, and that is absolutely true. Babies sleeping on their tummies need to be monitored. So if there is a concern and you need to put the baby prone because they're more comfortable in that position for reflux, then you have to watch the baby because you don't want them to turn their head and smush their face. But we do it in the NICU very safely because we have the baby that they have eyes on them all the time and they're on the monitor. So you want to show what the baby, what the prone positioning is? And this would be basically for the 30 minutes to 1 hour after a feeding. And then after that, remove them from that position. Like so that? Can you guys see? Maybe we don't need to see that, so we can do this. Can you guys see how she has the baby positioned? You want to make sure, go ahead, why don't you just explain the positioning?
Mm-hmm. So you have their head is facing to the side, so they're not like down. And you're gonna be watching them. So anytime you do tummy time, it's gonna be supervised until, well, when's a good time to start doing tummy time?
You guys they can start doing tummy time once the babies can move their heads from this position. If they can move their head like this, then you can start doing tummy time because you want them to start building up the head and neck strength. But you're gonna have to watch them and help them because if they get into this position, then you gotta help them get their face back. But if they can move their head from this position, you can do tummy time. But maybe 10 minutes a day initially, and then you can bump that up to twice a day, and then you can bump that up to 15 minutes.
And how many months can they start doing this? Like,
no, as soon as the baby can move. Yeah, if your baby can lift your head up as soon as you're going home, you can do tummy time right away.
Okay.
Yeah, but if you put a baby in this position and they don't move at all, then they're not ready for tummy time.
Okay. Right.
Okay, and then what about left side?
Oh, left
down.
side.
Yeah.
Oh,
so show us reflex precautions. This is what I want to see.
Anatomically, when you're laying on your right side, it's more likely for you to have reflux because it kind of.
Can you go back to the first slide with the picture of the baby?
There, yeah.
Okay.
So if you're laying on your left side, the milk is more likely to
This is the left. This is the left side of the baby on this picture.
Yeah.
So where the stomach is curving towards is the left side.
So if you can imagine them laying down, the milk is more likely to like pool in their belly rather than on their right side. It has a way to escape back up.
Yeah.
So that's why you want to put them on their left side.
Can you swaddle in position so they can see how you do left side down? So do you guys understand that physically? If you're down on this side, the milk will stay in the stomach rather than if you're on this side, it's more likely to go back up the esophagus. Yeah. So this is the safest at home, you know, in terms of not putting a baby prone, to put the left side down. So that would be the thing that we would start with, is put the baby left side down for the first 30 minutes to an hour after the feeding, and then you can roll them onto their back.
Well, I would have them up in there. I would have them up in this wedge so that they'd kind of be proper.
Oh, here, we can
Yeah, let's do that.
put that here.
So it's this way.
Probably need a little bolster
I
on the
think
back.
that's okay.
Yeah? Okay.
Yeah.
Okay, so this is positioning. Does anybody have any questions specifically about that? Body positioning. No? Okay. So the next one is the wedge, which we have talked a little bit about. It's basically putting the baby at an incline for the first 30 minutes to an hour after they have eaten. So the FDA and the American Academy of Pediatrics do not recommend wedges because they want babies to be flat and back to sleep because of the increased risk of SIDS. But there is one medical device that's a class 1 medical device for specifically for premature infants and issues with reflux, and it's this rescue wedge. So it stands for, it's got a cute name. I don't remember, but the RESQ will stand for something. But it's basically like the wedges that you're going to see on Amazon or on Walmart or in Target. But this one is designed by occupational therapists and a developmental specialist. And so the two positions are to be on their back in the harness so that they're safe, versus on their tummy. We see how the head is to the side, the position that Jenny was showing you guys. There are other positioners out there, like this one. What is this one called? What's this one called? Daydreamer. So the important thing is that they have these type of restraints to kind of hold the baby in position. But the big thing that you want to make sure of on any type of a wedge, and it's not that the AAP or even me as a doctor can recommend a wedge, but the most important thing if you're going to wedge position is to see what is the direction of the head. I don't need this one, right? So whenever you have a baby in any kind of a wedge position, or if they're in a boppy, or if they're in anything that you do, it's the head position that's the most important thing. So when you're on an incline, when you're in your car seat or whatever, even when we're fitting you guys in your car seats to go home, we're always wanting to make sure that you guys are aware that having the head forward, like if this is the car seat, having the head forward so that you're compromising your airway is not the position that you want to be in. You always want to make sure that the baby's airway is going to be open. No matter how you position, either in a car seat, on a wedge, in a bed, it's always about where is the head in relation to the airway. So you want to remove things that might push the head forward, and you just want to make sure that it's always in a position of safety, that there's airways open. And that's the most important thing that you guys need to remember if you're going to use any type of a device like this, is airway. Yeah? So once you have the baby well positioned so that the head isn't down like this but is open like this, then it would be safe. Yeah? Any questions about that? Okay. So some of the other treatments that we do for reflux, if we're finding that with mom's milk or with the preterm formula, that they're just continuing to have reflux and it's not working, one of the things that we start with, if you saw a gastroenterology specialist, would be a different type of a formula. They have formulas that have broken down proteins in them to make it easier to digest rather than intact proteins. So specialty formulas like Nutramigen or Alimentum, Neocate or Elecare might be the first step in terms of before you'd go to medications or whatever. And instead of using the Neosure or the Enficare that we recommend preemies use, we would have them switch to a Nutramigen or an Alimentum and see if that helps improve the reflux. If that didn't work, you can also sometimes thicken the feeds so they stay in the stomach a little bit longer. So that's like putting a little bit of rice cereal in the breast milk or in the formula. They make a formula that already has the rice cereal in it. It's called Enfamil AR. So that might be another option if there's still continuing to have ongoing problems. But this is like problems like the baby's not gaining weight, they're irritable all the time, they're not sleeping, things like that. And then if you get to that point, then you would be into the era of maybe medications. Babies want to be held 24 hours a day if you could let them. Totally. And they would want to sleep in your arms if you would let them, and then feed and then go back to sleep and have you walk around and cradle them. And if you want to try and put them down so you can go to the bathroom or have a shower, forget it. So that's baby. That's not like a preterm baby or anything wrong with the baby. So you have to either have a lap baby that you just sits here for the next 2 years, or you be very strict and say, no, you're gonna lay in your bed and that's it. You can fuss, I'm gonna go take a shower so I don't hear you, but that's it, you know. So that's more of a behavioral thing. And so, you know, in the NICU, we aren't able to do that, obviously, because our nurses have more than one baby, so if they want to be held at that particular moment, they just can't. So sometimes they get a little more used to it in the NICU, like because they're just the nurses will let them fuss a little bit in their crib, especially if they're feeding another baby. So there's no real right answer to that type of a question, and we're basically talking about a baby who wants to be held all the time or on your shoulder, and if you try to put them on your back, they suddenly wake up and they're fussy and they're unhappy. But that's more of a baby personality thing than anything else. So it's a personal preference. You can have a lap baby and just learn to, you know, cover her head when you're in the shower with her, or you can put them down and let them fuss a little bit, but that's a personal choice.